I'm going to talk this morning a little bit about lung function testing, how we monitor LAM as time goes by, and how we treat airway symptoms, which is really talking about use of inhalers for LAM. So it's a bit of a dry topic, lung function tests, actually. But actually, they're quite important in the management of LAM, and I think it's probably sensible to talk about them because actually everybody has to have them quite done often. They're horrible to do, aren't they? No one really likes having them done. When you're sort of in the week where you're about to have them done, you start to get worried about whether the numbers will have changed, and it sort of reminds you that you have LAM when you've sort of spent the previous 3 or 6 months not thinking about it, hopefully too much. And so I thought it was good to talk about the importance of it. The other thing about lung function tests is you have to interpret them in the context of the whole person, not just exactly, if your FEV1 has gone down by 8%, is that 8% more bad? That's not necessarily true. So I'm just going to talk around some of those issues and a little bit about the evidence for that. And lung function, one of the things that they measure is airway function. I'm just going to talk a little bit about treating airway function with inhalers, because that's a bit of a sort of it's a bit of a dark art for people with LAM. There's no guidelines or anything. So the talk really is about lung function tests. What do the individual tests mean? How do we relate that to how your LAM is? And how do we track whether your LAM's stable or whether it's progressing? And I'm also going to talk a little bit about inhalers and LAM. So when we make an assessment, when we see someone with LAM for the first time, about how bad their disease is, we use different measurements really. I'm just going to talk a little bit about each one. First thing that we look at usually is a person's lung scan, and that's often how the diagnosis of LAM gets to be made, because you see the characteristic appearance on a scan when someone comes to see you with respiratory symptoms. Then we assess severity a bit by doing different lung function tests, and we heard a little bit about those in the rehab session this morning. And of course there are also the symptoms and how people feel themselves, which is perhaps the most important thing that impacts on quality of life and function. So we do CT scans a lot. And they're more complex and they're more costly and there's more radiation than an X-ray. But we have to really do those because very often the X-ray in somebody with mild LAM, like this one here, is completely normal. You can't see mild LAM on an X-ray. You can see more advanced disease sometimes. X-ray is a useful screening test, but actually you miss a lot of the lungs. The area behind the heart's invisible, the area under the just behind the diaphragm domes is invisible, and you just get one picture from front to back. If you do a CT scan, you get maybe 100 slices through the lungs in much more detail. So just to orient you with a CT scan, so when you have a CT scan, like our little cartoon person there, you're lying on a table, and they slide you into the scanner, so it's like being sort of in the middle of a giant donut, which is maybe a fantasy for some people, I don't know. And what we see is a cross-sectional picture through the person. And so if you imagine that you're looking at a cross-section from the direction of feet, the scans begin to make sense. So this is a normal CT scan. So the scanner table are those lines at the bottom of the picture. And so the patient's back is lying on the table, so that's the spine, and then the top of the picture is the front of the person, and that's the breastbone, the sternum there. That's the heart in the middle, and then you can see the right and the left lung sort of on the wrong way round, but as I say, if you imagine you're looking from the feet, it starts to make sense. And this is a normal background grey colour. I'm not sure how well it's going to show up at the back actually, but the lungs look this sort of background neutral grey colour. The white things are blood vessels mostly. And so this is a normal scan. And this is a scan of somebody with LAM. So these cysts are the hallmark of having LAM. So actually what you see here, most of the lungs, the normal grey colour, this is somebody with fairly mild disease, and then they have these cysts from in place to place, they have little walls around them, and this is what LAM looks like normally. As the disease progresses, the cysts sort of become more numerous. As I say, this is somebody with mild disease. They've got fairly normal lung function. This person has really quite severe LAM, and you can see that there's lots of cysts and not much lung tissue. Now, it's quite easy to tell the difference between the first one, the mild case, and this more advanced case. But actually, for monitoring the disease as time goes by, doing CT scans regularly don't tell you that much. So if you did one every year, it would be very hard to see if there were more cysts or the cysts were a little larger year on year. And it's hard to measure these precisely by eye. There are programs that you can use, but they're not really in routine practice. Having a CT scan is maybe the equivalent X-ray dose of 100 chest X-rays. And so, although it's okay to have 2 or 3 CT scans over a long period, if you did them every year, starting in your 30s, then the radiation dose would mount up, and that's not a helpful thing. Although there are various groups, including the LAM group at the NIH, working on low-dose CT scans, so perhaps we'll be able to use CT a bit more for monitoring people in the future. So the way we monitor people is not to do the scan every so often. It's always nice to have a picture to look at rather than a whole list of numbers, but actually the lung function tests are more accurate and more clinically useful, and we understand the trajectory of them a bit better. So I'm going to talk a bit about lung function tests now. So in sort of pretty basic terms, the main compartments of the lung are the airways, so the trachea and the bronchi that branch out and split about 24 times to make the airways, and these move the air from the mouth down to these little sacs at the end, which are the alveoli. The alveoli's job is to take oxygen from the air, get it into your bloodstream so it can make energy to power your muscles and do all of those other things, and get rid of waste products. The other key bit of the lungs is the blood vessels that run through them, where that get the oxygen and take it around the body. So LAM affects the airways and the alveoli differently. And to get a full assessment of LAM, we actually need different tests. So we need tests of your airway function, and we need tests of your alveolar function. And so most of you, when you come for your LAM reviews in most places, will have more than one type of lung function test. You usually have the group of tests called spirometry, and you'll usually have an estimation of your gas transfer. There's other things that you can do, but those are the sort of 2 things I'm going to sort of focus on really. So this is the main test of airway function. This is spirometry. So this is the one. Take a big breath in from the room, blow as hard as you can till you're empty, then breathe in till you're full again. Usually, see, here's somebody blowing away. This measures the maximum breath you can take. So, or FVC, which stands for forced vital capacity. So that's a maximum volume of your breath. For most women with LAM, that stays fairly normal, actually. The other thing it measures is how quickly the air flows through your airways. And the test that we use to record that, for the most part, is this thing called FEV1. When you do the spirometry test, you get one of the ways you can represent it is in this type of trace. So this is the amount you blow out on the vertical axis, and this is how long it takes to empty your lungs on the horizontal axis. So if you look at the blue line, somebody with normal lung function, you can see that actually most of the air comes out of the lungs. Actually, there's no time scale on there, but within about 2 to 3 seconds on the whole. And this measurement here, where the line is this FEV1 measurement here, that is the volume that you blow out in the first second, and that's usually about 70 to 80% of your total volume. The person with, let's label it obstructive here with this red line, I think it is, has narrowed airways. So what you can see is they can empty their lungs pretty much to the same extent as the person with normal lung function, but it happens over a longer time period. Their airways are narrow and the flow is slower through those airways. And so after a second of blowing, they've probably only emptied about a third of their lungs, maybe a little bit less. And actually, as LAM progresses, this FEV1 value tends to fall, and it's one of the best understood markers of disease progression. The other thing that spirometry tests tell you is if you can change airflow by relaxing the muscles around the air passages. So if you give somebody a drug, a bronchodilator, that relaxes the muscle around the airways, you can see that this is the same person before they've taken the inhaler and afterwards, and you can see that they've been able to blow out more air and it's come out more quickly. Will I put the animation on? Oh, no, I haven't. But, and you can see that there's a sort of an increase here in the amount of air that they move out. And that, if you have airway narrowing, that's often a useful benefit in terms of improving symptoms. So the other group of tests that we follow is a measure of gas transfer. So to try and get a handle on how efficiently the oxygen in your air spaces, your alveoli, gets into your bloodstream, which is the main job of the lungs, really. And that's called DLCO, or sometimes TLCO. So that's diffusion in the lung of carbon monoxide. And we use carbon monoxide as a tracer gas. Now, everybody knows that's poisonous, but it's a tiny amount. So what happens when you do the test? So this is the one where you blow out till you're empty, breathe in till you're full, hold for 10 seconds. That's always a good bit, isn't it? And then breathe out into the machine at the end. And what you breathe in is a tiny amount of the tracer gas, some helium, and mostly air otherwise. And the more of the tracer gas that gets into your bloodstream, when you blow out at the end, there's less of the tracer left because it's gone into the bloodstream. So we can quantitate how efficiently you get gases into your bloodstream. So it sort of measures oxygen uptake, but that's really how well matched the blood vessels and the alveoli are in the lungs. Normally, the alveoli the blood vessels are right round the outside of the alveolar sac, and so there's a very short distance that the oxygen diffuses into the bloodstream and the carbon dioxide diffuses out. Measuring the gas transfer for people with LAM particularly is more sensitive to changes in the lung structure than measuring things like the FEV1. What you see in people with LAM is sometimes different patterns of change. Some people have low DLCO and fairly normal spirometry, and sometimes less commonly the other way round. But most people lose FEV1 and DLCO somewhat in parallel, and we'll talk about that a bit later. Much less is known actually about what happens to this measurement over the course of LAM than FEV1, which is surprising considering it's usually the first thing that changes. So when you have your lung function tests, you usually end up with a whole pile of numbers like this, which is much less interesting really than the CT scan. What we do is that we look at your values and then we compare them with what they should be. And to do that, somebody has recorded the lung function of lots and lots of healthy people and looked at how that changes with age, how that changes with height, and how that changes with ethnic origin. All these three factors affect what your lung function should be. So if you look at these lung function tests here, you get all these different columns. The first column here is the predicted value. So this says for somebody of your age, of your height, of your sex, and of your ethnic origin, what should your lung function be if it was completely normal? The next column is the lung function that we've just measured from you, and then the column at the end is the percent predicted. So that's the easiest thing to interpret. So that's your values compared with other women of your age and height as a percentage. Now the normal ranges are quite wide. So like in the same way that people's feet and noses are sort of different sizes, people's lungs tend to be different sizes, even for people of the same height. So the ranges are quite wide. So So if we look at this person here, this is the value for FEV1. Well, let's try and do the magnify thing. And so if you look at their FEV1 here, predicted is 2.6, theirs is 2.7, and so that's 104% are predicted. So that's spot on normal, really. This is a person with LAM. Like many people with LAM, the spirometry may be almost normal. This person's gas transfer, the diffusion measurement I've just spoken about, there should be 8. Theirs is 4.5, and so it's just over half of the predicted value, and we often see this. And one of the tricky things about this, of course, is if you go to your GP and have a lung function test with the practice nurse, for example, which is commonly done, they only do the spirometry. So they'll say, oh, look, your lung function's completely fine, don't know why you're breathless, just get a bit fitter or something like that. That can easily happen, and no doubt has to some of you. So you need to do the different lung function tests to get the proper picture, really. But as I say, the range is quite wide. So for the percent predicted, actually everything over about 80 is in the normal range. And so some people might start off with lung function of 120. Obviously, if you start off with high lung function, if you're going to get a lung disease, you've got a bit more in reserve. That's a generally good thing. But the ranges are fairly wide. So if your DLCO is 80, it might be normal. It might not necessarily be low. And other things can affect lung function without really affecting the lungs. If you have a pneumothorax and then need a pleurectomy, an operation to fix the pneumothorax, your chest wall won't move so much after that, and particularly in a couple of months after the operation, your lung function might be a bit lower. It doesn't mean your lungs are worse, it just means your chest doesn't move so much and your lungs are constricted by that. So you have to look at them in the context of everything else. So the other type of tests that we do are walking tests, and we heard a bit from Maria this morning about these types of tests and how they're used to assess pulmonary rehabilitation, and they're important because they're functional sort of tests. And they sort of tell us a bit more about real-world performance. And although somebody with low lung function would be more likely to have worse results on a walking test, there's not a direct relationship. So there's a couple of things we do. There's a 6-minute walk test. It takes an hour. And that's because you have to have 2 goes as a little practice go, and then you have to recover and do it again. So crudely, it measures how far you can walk. And that depends on how good your lung function is, but also, as we've heard really nicely demonstrated, how good your leg muscles are, how fit you are otherwise, how determined you are, how much you want to beat the record of last time. And there are people that come with their training shoes and ask what the maximum distance is. Not saying who those people are, but anyway. And the other thing it measures is what your oxygen level is when you're exerting yourself. You should really be able to keep your oxygen level steady as you work. As you're walking, your muscles use more oxygen. Your lungs have to keep up with the extra demand. They should be able to. If your lungs aren't working to their properly, then your oxygen level might fall. And so this gives us information on this, and it's sort of not completely related to lung function. The cheap and cheerful version of this is a corridor walk test, where you just get the person to walk up and down until they're a bit breathless, measure their oxygen saturation with a little finger probe. That just takes a few minutes. It measures whether people's oxygen falls with exertion, which is helpful. So if you walk somebody up and down the corridor or up and down the stairs and they get out of breath, if their oxygen's fallen, their main component of breathlessness might be their lung condition. If their oxygen's pretty okay, it hasn't really changed, but they're quite out of puff, then there's an element of deconditioning, of fitness there, and that's often reassuring for people, and we can sort of tackle that with things like the rehabilitation that we heard about earlier. So we measure those things. So these are just a few people who've done corridor walk tests. So this little dot is the starting oxygen saturation. The green zone's completely normal, the white zone's sort of okay, and then these are lower values down here. And so before the walk, you can see that everybody's saturation's sort of okay. After they've walked up and down and got breathless for a few minutes, you can see that although some of the people who start off lower have big falls, that's not always the case. And there are people whose oxygen doesn't change a great deal when they walk, and it's not completely related to their lung function. So this tells us something extra. So all of these different tests help us to manage people. So when we're trying to say, how bad's my LAM, we look at what your lung function is like, in terms of your airways, your gas transfer. We look at your scan, how many cysts have you got, and we also look and see what your exercise performance is and what happens with your oxygen level. But of course that's not the whole thing. You're not just a load of numbers. It varies. Other factors are important in terms of, your exercise performance might be a bit lower if you're older. If you've had LAM for a very long time and your lung function is a little bit impaired, that probably means you've got fairly mild disease because you've had it for a long time, it hasn't got too bad. If you're younger with impaired lung function, that's perhaps more important. What's happened to you before is important. What other LAM symptoms have you got? Do you have chylus problems? Have you needed surgery for things? And of course, what your symptoms are. Some people have quite bad symptoms in the presence of fairly normal lung function, and some people have impaired lung function and actually aren't too bothered by things. And so all of these factors sort of go in to work out your LAM. So what I'm sort of saying in a very long-winded way is when you look at your FEV1 and say, oh, mine's 70%, that's not so good. If it's been like that for a long time and you basically don't have very many symptoms or other problems, that might be quite good and quite reassuring for the future. It's not just about lung function, it's about everything. So that's a sort of baseline assessment. When people come up for their assessment, the people we see, if you see somebody once or twice a year, actually, I hadn't realised this at first, but people get quite stressed by just the fact that their appointment's looming and what's happening with their lung function. Does it mean that I'm progressing or are things stable? We spend a lot of time trying to work out whether disease is progressing or not. So what you have to bear in mind, of course, is that everyone, their lung function, along with a lot of other things, get lower with age. So for a normal person, your FEV1 value will fall by about 20 millilitres a year. If you have LAM and you're not on any treatment, and these are from historical data because we try and treat people before this happens nowadays, you probably lose FEV1 at about 100 millilitres a year on average, although the range is from normal to much faster than that. And these lines are people's FEV1 over, actually, this is 280 months up to here, so a lot of years. Each line's a person's FEV1. And so you can see there's a huge range here. So there are people up here with, this is 80%, so this would be normal. All these people have fairly normal lung function. This person I've highlighted in green there goes up and down, but actually it never dips into the abnormal range. Then you've got somebody with more sort of progressive disease here and somebody with really quite advanced disease here, and everybody in between. And so what we really want to do is see as quickly as we can as to which trajectory we're on. And the importance of this, of course, is this person needs some treatment, this person needs some treatment, this person may never need any treatment. So we don't want to give them a drug that they have to take for life, that has side effects, that needs monitoring, that they might not need. And our challenge often is to work out which trajectory they're on. And that's where things get tricky. Of course, just to remind you all, these are people who never had any treatment because there wasn't any available. Now we have rapamycin, we can level this out really quite nicely, and I'll talk about that a little bit later. So the big question is my disease progressing, which is in everybody's minds really, is often tricky to answer, and this is why really. If you do your FEV1 every day, it can go up and down by about 5% if you have normal lung function. If you have airway narrowing, it varies quite a lot more. And in this very old paper where people used to look at lung function a lot in the olden days, because that's all we had, they saw that the change really had to be about 17% to be significant. So a 17% change, if your FEV1's 2, I should have worked this out beforehand, shouldn't I? It might go up to sort of 2.3, 2.4, or down to 1.6-ish, and they might all be the same. They might just be natural variation. But if you looked at your lung function and you went, oh look, it's quite, it's 200 milliliters lower, you'd be worried. But you don't necessarily have to be. And I spend a lot of time saying this to people. So your tests might vary, but your lung function might not be that different really. And this is what sort of happens. So this is somebody's lung function over a few years that I look after. So say we're seeing her on this day here. These are the FEV1 values, and these are the gas transfer values. And the FEV1's about the same as the last visit. The gas transfer has gone from 5.7 to 5. Okay, so is that bad? Is that worse? I mean, obviously, it's always disappointing when lung function falls. Should this person be worried that their disease is progressing? Well, if you just wait and do it again, the next time, a few months later, it's actually gone back up to pretty much the same level as there, and then a few months, a year later after this one, it's still the same. And so this is just natural variation. If every time you come, it's a little lower than the last, that's a different thing. But these are quite variable. So when you have your lung function and somebody says to you, you look at the numbers, they might be a little bit lower, and everybody goes, oh, that's about the same. You sort of go, but isn't that a bit lower? And you sort of, people don't really believe you about this. And the other side of the coin is if they're a little bit higher, goes, oh yes, it's great, that's really good, it's a bit better, isn't it? Well, it's about the same. And then people seem quite sort of disappointed by that. But it's natural variability. And the main thing to do is to not panic with these small changes. This is a person with LAM. So there's 12 years of FEV1 tests here. And you can see that this is a person before we had rapamycin, and the lung function fell gradually, and it's sort of going down fairly steadily. But just imagine if you were seeing them just at the beginning of this trajectory. Actually, the slope of change is actually it's probably getting a little bit higher overall. Then the next bit it goes down, then it sort of levels out, and then it levels out a bit more. So if you look over a short period of time, you get quite confusing answers as to what the overall trajectory is, because if you remember, actually, it's probably just a fairly smooth line for a long period. So one of the things that we've been trying to do is to try and work out how reliable lung function tests are. So poor old Jan. So she ran LAM Action for 20 years, and then she sort of retired and thought she thought, oh, I'm done with LAM now. But what happens now is that one day a week she comes in and mines lung function data, doing research into LAM, and these are some of the things she's done. And what we've been trying to do, the two of us, is answer these questions about how variable lung function is. So Jan used to be a lung function technician in her previous life, and now sees more lung function tests than she perhaps wants. But what she's done here is those long slopes with lots of points in, what we've tried to do is we've said, what's the real slope using all the points? And we've said, okay, so maybe the change is 100 millilitres a year. So if we saw the first two measurements of that, what would the slope look like then? And then if it was 3, and if it was 4, and if it was 5. And what we see, these are graphs of variation around the real value. And so if we measure anything less than about 6, 7, maybe 8 sets of lung function, the variation's so wide, it's just very confusing. And if we look for shorter than a 1 year period, which is about down here, the values are quite confusing. So we really need about at least 6 measurements and maybe a year of looking to see whether your lung function is stable or changing. So just having one test isn't super helpful. Now this is a problem for looking after people with LAM, because we want to actually get people on treatment as soon as they need it, but not treat people who don't need it. And we don't really want to wait for a year or 2 years till we're sure what's going on. So how do we decide whether somebody's LAM's getting worse? Well, we look at the lung function, obviously, but we also talk to people. Are they getting progressively more breathless? Is their exercise performance dropping off? If somebody's lung function looks like it's falling a little bit, but their symptoms are completely unchanged, then it's probably not actually. If they're getting more breathless and the lung function's dropping, then we take that more seriously. And we follow the trend in lung function. The more time and the more points, the more reliable it gets. Of course, you have to take this in context. If your initial lung function is really quite high, the variation doesn't have much of an impact. We might still want to prevent any loss of lung function. We also have to make sure that it's not something else that's affecting the lung function test, like have you had lots of infections and is it a bit low because of that? Have you had a pneumothorax or an operation, or is there some other problem that's making your lung function worse? So one of the things to try and work out whether we can predict more quickly whether your lung function is changing is to also use DLCO. Most people look at FEV1. We looked at all of the patients with DLCO. Again, this is something Jan's done. So if you look for all our patients who are not on treatment with rapamycin, FEV1 average falls 82 millilitres a year. The DLCO falls by 0.17, a little bit faster before the menopause, a little bit slower afterwards. And if you sort of plot these out, if you compare how FEV1 changes with DLCO, each one of these lines is how these two lung function measures change together in the same person. So if they were changing at the same rate, all the arrows would run down here. What you see is most of the arrows do run down here, but there's nobody, well, very few people in this box. When we see people, their DLCO has already fallen out of this normal box into these slightly abnormal areas here, but their FEV1 is still roughly normal. So what I think these data mean is that your DLCO is probably the first thing to go down, and before you're diagnosed, it's sort of creeping down a little bit, whereas your FEV1's relatively well preserved. As LAM gets more advanced, actually they seem to fall together as far as these data suggest. It also tells us an interesting thing about rapamycin. So this is the same sort of thing. These arrows are summaries of all the arrows, so it makes it a little easier to look at. So the good news is, these are our patients, remember, no treatment for FEV1 changing by 82 millilitres a year. If we give people rapamycin, FEV1's completely steady, or actually +8. It's getting a little bit better. That's even stopping the aging change. So rapamycin's very effective at stabilising FEV1. What we see is that actually the DLCO is still going down a bit. Perhaps half as quickly as it did before, whereas the FEV1 pretty much stabilises. And these little arrows here, these are the people on no treatment, the blue ones. The red arrows, they change direction. So the FEV1 stays where it is, the gas transfer drops a little bit, and that's what we tend to see. So I think doing these DLCO measurements tells us a little bit about what's happening with rapamycin, and it tells us about early disease. So one of the things that we're doing at the LAM Centre now is taking a bit more notice and recording the DLCO values in a bit more detail to plot patient trajectories. So to summarise all of that, which was for the train spotters really, wasn't it? Spirometry and DLCO tell us about the degree of lung damage. Walking tests add information about function. And the severity of the disease, you have to synthesize all these bits of information and put it together and look at the whole person in front of you. And so it's not wise to get too hung up about small changes in your lung function. Over the short term, it's quite difficult to monitor what your lung function is doing. And DLCO is handy in certain situations. For people with very early disease and for people with rapamycin, it looks like from the work that Jan's been doing recently. And really, there's no substitute for talking about where you think your disease is with your doctor, rather than just looking at your lung function tests. And the other thing that we need to do, and one of the things that when people come to the LAM Centre, nobody has not signed up for this research project. It's an amazing response. We're looking at blood tests and other markers that will predict change earlier, or even predict prognosis before it happens. And that's one of our ongoing plans, because that's one of the things that's an important need for looking after people with LAM. So just going to do 10 minutes on inhalers for LAM now. So actually, inhalers modify airway function, and they're probably the most commonly used drug for LAM. Many more people take inhalers than use rapamycin or use oxygen or any of the things. There's absolutely no evidence whatsoever about who should use inhalers, about which inhaler they should use, when they should use them, and what to do. So we've been trying to sort of gather a bit of evidence around those questions. And we certainly see a lot of this sort of thing. So people go to their doctor because they're breathless and they're wheezy, they're a young person, and so a diagnosis of asthma often gets made. And then someone finds out they have LAM eventually. I've seen this quite a few times, people saying, well, I'm not on any treatment now. My doctor stopped all my inhalers when I didn't have asthma. And of course, these inhalers were for treatment of asthma, and yes, the person probably doesn't have asthma, but they